invitation. I will speak today about RASS blockade is nephroprotective. As we know that renin has been discovered more than a century, and RAS inhibitors are very famous to be cardioprotective and nephroprotective, but I will speak today about its being, of course, nephroprotective. My agenda will be the journey to prove that RAS blockade is nephroprotective, RAS system, RAS blockade in CKD. Let us start by the journey how we'll prove that. Usually, we may have a knowledge. This knowledge gives us information. The information gives us creative idea. This creative idea has a logic to be rationalized. And according to this rationale, we can design pilot studies, small studies, observational studies, and cohort studies, randomized controlled trials, meta-analysis, guidelines. And according to what I have mentioned, we may reach a fact, and this fact became a guidelines and be written in textbook. This is our journey today to prove that they are nephroprotective. What about RAS system? We know that renin is released from the macula densa. It will convert angiotensin to angiotensin 1, and the ACE will convert angiotensin 1 to angiotensin 2, which will act on angiotensin 2-1 receptor, which is deleterious effects regarding hemodynamics and inflammation on the kidney. And as we can see, the angiotensin 2 will reduce the GFR, increase proteinuria, increase aldosterone release, induce glomerulosclerosis with great injury of the kidney. As we know that the glomerulus have afferent arteriole and deferent arteriole. The afferent is usually controlled by vasodilators, especially prostaglandins. The efferent is mainly controlled by the angiotensin 2, which is mainly vasoconstrictor. As we know that when we are using ACE inhibitors or ARBs, we'll make slight dilation of the afferent arterioles with more dilation in the efferent arteriole with lower GFR, and of course this is nephroprotective through reduction of intraglomerular pressure and glomerulosclerosis. As you can see here, ACE and ARBs can reduce GFR through mainly dilation of the afferent arteriole. In spite that, when we are using ACE or ARB, there is initial drop in GFR, but on the longer term, due to reduction of the intraglomerular pressure and reduction of glomerulosclerosis, we have a long-term benefits. RAS blockade include direct renin inhibitors, ACE inhibitors, ARBs inhibitors, and of course, mineralocorticoid antagonists. But we'll speak today mainly about ACE and ARBs. What about RAS blockade in CKD? What about studies and randomized control trials? Usually, the first study, the idea started in 1977, but the first study was started by Lewis in 1993 on diabetic patients, CKD patients, where there is reduction of the doubling of the creatinine, 30% reduction of proteinuria, and reduction of GFR and dialysis and mortality. This was, the player here was captopril, which showed 30% reduction in proteinuria, 43% reduction in doubling creatinine, 50% reduction in percentage of patients who died or required dialysis. To that, captopril, when against placebo, it's shown it is a nephroprotective drug. The next study in non-diabetic was 1996, was through pinazipril, which showed reduction of doubling of serum creatinine in 53% of the situation, and it was proved to be nephroprotective. The third study was the famous study, RAIN study, which was ramipril against control. It had make marked reduction in the proteinuria and deterioration of the GFR, and so that it was really nephroprotective. The fourth study was the ACE inhibitors through the ASC study, ramipril against amlodipine. It shows reduction in the duration of the GFR and reduction of mortality and in this stage kidney disease. And this is extension of the ASC with the same concept. So that for the ACE and its role in non-diabetic CKD, RAIN study and ASC study and the study by benzapril 2006 showed that they are effective in reduction proteinuria, slowing GFR decline, reduction of risk of doubling serum creatinine or progression to end-stage kidney disease, and of course they are nephroprotective. So the conclusion that ACE inhibitors are nephroprotective drugs away from its blood pressure reduction in diabetic and non-diabetic patients. What about the ARBs? The first important study was the RENAL study in 2001 by losartan against placebo. It prevents doubling of serum creatinine and the progression to end-stage kidney disease, and also it makes marked improvement for proteinuria. So that This is very important. Followed by what's known as the PRIME program, which was in the early situation by the ERMA2 study and at the late situation by the IDNT. The PRIME has shown that it prevents progression of micro to macro and proteinuria significantly, and ERMA2 also shows normalization of microalbuminuria towards normal albumin excretion, while the IDNT study have showed that it prevents doubling of serum creatinine and retarded its doubling. It retards progression to end-stage kidney disease and mortality when it's compared with amlodipine and placebo, and it was a very effective in this situation. So that irbesartan slows progression of type 2 diabetic nephropathy. So that's the conclusion through the IDTN, the ERMA, the RENAL, the MARVEL studies. They were very effective in preventing and reduction proteinuria and preventing deterioration of the GFR and delayed progressive kidney disease. So that ARBs have renoprotective effect beyond their effect on blood pressure. They have similar, of course, cardiovascular effect, and they are very effective, especially in type 2 diabetic patients. The main three major trials was Lewis, the first one, 1993, REAL 1997, and RENAL 2001. This is a very important study because it was knockout for this group of population. Here, we have seen that renin-angiotensin blockade in normotensive, normal immunic patients, the micro-HOP study have been renoprotective in 24% of situation and the cardioprotective in 37% of situation. So that after this study, it's over, game is over. Here, the idiom, the sacred cow, معناه البقرة المقدسة. It's over. Nobody can dare to attack ACE or ARBs. They have proved himself, and nobody dare to be inside this play. And we have became at a higher level, which is more effective, ACE or ARBs. The detailed study in 2002 have showed that telmisartan and enalapril, there is no difference between them regarding their nephroprotective effect. Another trial, 2004, showed that telmisartan and enalapril, no difference as nephroprotective effect. They have tried a step forward to make combined ACE and ARBs, but really the target study has forbidden this combination. Even in patients with renal insufficiency, when you are trying to protect your heart failure patients by ARBs or ACE, it was highly protective. So we can see here to the previous studies, we have mentioned another studies, which is Morris study, Bilus study, EMA study, Holler study, Hearst study, Vijayakama studies. All these studies have proven that ACE and ARBs are nephroprotective drug, in addition to the main studies which are collaborative study, RENI study, ASK, RENAL, IDNT, roadmap, and the nephron-D studies. Recently, 2018, very important study, which was made on about 8,000 patients. ACE or ARBs monotherapy have significantly reduced progression of CKD. They have retarded the duration of renal function among patients with CKD and hypertension. Another study, which is LARICO study at 2018, have shown that ACE and ARBs were very effective as nephroprotective, and they have delayed progression of kidney disease, and they were cardioprotective and decreased mortality rate. What about meta-analysis? The first meta-analysis was by Gatras 1997, showed that ACE were very superior to other drugs as a nephroprotection. Another meta-analysis by Casas 2005, they showed that ACE and ARBs are very effective regarding protection of the kidney. What about other meta-analysis? 2016 was a great meta-analysis that showed that it was carried about more than 100,000 patients. They show that ACE and ARBs are similar in renoprotective effect. Another study, which is another meta-analysis, which was the famous Bayesian meta-analysis, have shown that both are very effective, but the superiority for ACE inhibitors. But later on, a comment on this study that we need to revise it because they think that the superiority is not that obvious between the two groups. Once again, another meta-analysis. This meta-analysis showed that here both are of the same superiority. Nothing is superior to the other. Here another conclusion, study meta-analysis showed that both groups are very effective as nephroprotective drugs with no superiority, but there is a slight superiority to the ARBs because there are fewer side effects. And here, because of the fewer side effects and drug withdrawal regarding the ARBs, they are slightly superior from this point of view, but as efficacy, both are equal. This is another meta-analysis showed that the drug of choice in CKD, first choice ACE inhibitor or ARBs. This is another, of course, meta-analysis showed that when you have proteinuria, ACE or ARBs are the first drug of choice. This is the most recent meta-analysis that shown that 2020, this year, showed that they are very effective drugs, retard the progression of chronic kidney disease, mortality, cardioprotective, but here the superiority is towards slightly to ACE. So that medications are proven, RASS, to be used thoroughly in CKD patients, especially if they are diabetics. What are guidelines? GNC8, they have concluded that CKD patients with hypertension should use or start ACE or ARBs. European Society of Cardiology have mentioned that the priority to start with ACE or ARBs plus a second drug. The American Society and the American Association of Cardiology showed that here the superiority, if you have microalbuminuria, it is much better to be the ACE superior to other drugs, but if there is no proteinuria or are equal. Here, as we can see in this drug, this is the Canadian guidelines showing that when you have proteinuria and CKD, the priority is for ACE, then ARBs. What about the latest guidelines 2020, not 2012? They have shown that they are recommending ACE or ARBs for diabetic patients, hypertension and albuminuria. Of course, when you have albuminuria, either diabetics or non-diabetics, ACE or ARBs are superior. But here is the addition that you suggest RASS in CKD diabetic patients, even if they are normal albuminuria. This is the addition. And they suggest ACE or ARBs as a first-line therapy for high pressure, blood pressure in children with CKD. So that all of these meta-analysis, trials, guidelines, all of the guidelines were towards, of course, ACE and ARBs, so it became a fact. And this fact have been written in the guidelines textbooks, nephrology, cardiology, internal medicine, diabetology, and others. All textbooks have mentioned that ACE and ARBs are nephroprotection, and here all the debate, which is more superior, can we add double agent? Of course, this was on target study, have aborted this process because of the higher, of course, side effects. The side effects may be in the form of hyperkalemia or AKI. In this situation, we will omit or reduce the dose of these drugs, but all over, randomized trial, controlled trials, all studies, meta-analysis, guidelines, all of them said that ACE and ARBs are superior to other drugs. And here the debate, they are not that effective. They are written in books as effective. The debate is which is more superior. And thank you.